Good evening, everyone. I'm Vincent, physiotherapist from Tata Memorial Hospital, Mumbai. I welcome you all for this webinar on behalf of Society of Indian Physiotherapists. As otherwise called a SIP is a flat forum that provided much needed platform for Indian physios to have a healthy discussion on many clinical and research interactions. Today's topic, as you all know by now, is palliative care in cancer, role of medicine and physiotherapy, which is very close to my heart. We have two renowned speakers, one from oncosurgery field and another from oncophysiotherapy field. Like most of you, I'm eager to listen to them. Therefore, without much ado, I wish to introduce the first speaker of the webinar, Dr. Archit Pandit. Dr. Archit Pandit is a surgical oncologist whose area of interest is thoracic and gastroesophageal surgeries. After being awarded the Best Outgoing Surgeon in 2008 from Rajiv Gandhi University of Health Sciences, Karnataka, he received his training in surgical oncology at the Department of Surgical Oncology, AIIMS, New Delhi. With 8 years of post-MS in general surgery and academic experience in surgical oncology, he is presently working as a senior consultant at Max Institute of Cancer Care. His focus is thoracic and gastroesophageal malignancies, which also include the minimal access oncology, surgeries for which he received Video Award in 2013 at Indian Cancer Congress and Best Video Award at Asian Clinical Oncology Society in 2016. Though he has publications in all the fields of oncology in reputed international and national journals, his clinical research has been mainly focused on esophageal cancers. After finishing fellowship in laparoscopic and robotic oncology, he has been doing laparoscopic gastrectomies, open lung surgeries, which includes lobectomies and pneumonectomies, and thoracoscopic esophageal surgeries, and has published many papers in this field. Over to you, Dr. Archit.
Hi, Dr. Vincent. Thank you very much. On the sidelines, I would like to thank the Society of Indian Physiotherapists and Dr. Nitesh for having me on board and giving me this very, very important topic about palliative care and rehabilitation in cancer patients. Now, I must admit over here that when I was given this topic, I wasn't very sure whether I'll be able to do justice. But when I started preparing this presentation, I must tell you that I feel that there's no one better than me who can actually tell you that what is the need of understanding the role of physiotherapy and palliative care in treating cancer patients holistically. This is one of the most important aspects that we need to understand and absorb. Unfortunately, not many treating cancer physicians, surgeons understand, including me, understand the actual need for this in our clinical practice. So here I am with my physiotherapy team. I think it's a physiotherapy day, so happy physiotherapy day to everyone. And this is one place where I think I should not take the stage, and I should give all the credit to my physiotherapy team at Max Institute of Cancer Care, Shalimar, Bagh. Dr. Rohit leads the whole team, and we are fortunate. Honestly, we are really fortunate to have such a wonderful team, and I'm sure every physiotherapist who's watching this at present is an exception in providing care to these cancer patients who really need passionate care, to be honest. So my whole concept is about a buddy who has always had my back and has always kept me protected. Now, I will try to not have the audience look like something like this. So this photograph was taken from Climate Change Conference in Paris way back in 2018. And this is actually a real photograph. So this is where Sartaj Aziz is sleeping, the first one on the left side. And just along with it, Kerry, he looks almost dead. And I'll try that none of these faces actually happen while the presentation is going on. Abdullah, he's like looking drugged already. And Nawaz Sharif has just smelled a fart, as if, something like that, sort of a expression that you can see. And David Cameron, he's the perfect one, like as if nothing has happened. So probably the one who has actually done that. Well, so let's come to what has happened in the field of cancer surgery over the past 10 to 15 years. Now, this is if I have to really put everything in a nutshell, I would just finish the whole presentation in just this one slide, wherein you can see how the evolution of mobile phones has happened from wired phones. I don't know, many of the physiotherapists who are right now watching this presentation would rather not understand what I'm trying to say when I say wired phones, because that is something that they have never ever experienced. So, the size of the phones have gone down. There's a lot of multitasking happening nowadays, and so has the evolution of man, and rightly so has the evolution of cancer surgery also has happened over the past 10 to 15 years, over the past 2 decades or so. Just to bring things into perspective, I would say that this is how a breast cancer used to be operated upon. Now you can see on the left side, this is a radical mastectomy, wherein at the end of the surgery, you would just see bones and skin. That's it, nothing else. And now, at present, we are offering patients breast conservation surgery. Now, the lymphedema part that happens is because of the complete axillary lymph node dissection. However, we have grown above it, and now we are doing sentinel lymph node dissection, wherein the whole of the axillary lymph node need not be removed, hence preventing lymphedema. However, there is a caveat to it that these subset of patients are only those who have early breast cancer disease. And hence, not every patient would rather go for a sentinel lymph node biopsy. So if you ask me, in my clinical practice, only 10% of the patients actually get to undergo a sentinel lymph node biopsy. That is when the axillary lymph nodes are negative, and hence get lymphedema prevented. Now, this is what happens. I don't need to tell you. You all are the expert of how lymphedema happens when you do a pelvic lymph node dissection in a case of radical hysterectomy for CA endometrium or carcinoma of the cervix, or be it lymphedema of the arm when you do a surgery for breast cancer, when you do a complete axillary lymph node dissection. Now, this keeps on growing and you get an elephant limb, which is actually a terrible thing to have. The other advancement that has happened in cancer surgery is the incisions have gone down, the recoveries have gone up. Now, the lung cancer surgery, wherein we used to make a big incision, as you can see on the left side of your screen, has now gone down to 3 keyhole surgery. That is what we do at Max. Now, this is the incision for a robotic esophageal cancer surgery, whereas a small incision in the abdomen, 1 centimeter incision, and similarly in the thorax, wherein you do a 1 centimeter. So this prevents pneumonitis. This improves the lung function. The circulatory disturbances are reduced. So the early survivorship complications are reduced, as opposed to the long-term survivorship. That is where the rehabilitation program needs to pitch in and come in. Now, this is what we have achieved in performing colectomies for cancer of the colon, cancer of the rectum, wherein such big incisions have reduced down to 5 millimeter or 1 centimeter incisions in the abdomen, reducing the stay in the hospital, reducing circulatory imbalances, complications like embolism, having an early rehabilitation phase in the post-operative period. Now, again, all of this caters to early rehabilitation programs. However, we don't think much about the latter consequences of such major surgeries. Now, for example, in oral cancer and reconstruction, now this is the patient who had a huge mass in the tongue. You can see the first two photographs, and on the right side, you can see how the microvascular reconstruction has helped, wherein we anastomose the vein to vein and an artery to the artery with the help of the microvascular plastic surgeons, and help in giving a good cosmesis, not just a good cosmesis, but a good speech output, a good deglutition, a good swallow for these patients. So I would say, as compared to 15 years back, our complications, at least the early recovery complications, have definitely gone down. Now, this is a patient we have also, my head and neck oncology team has published this, sent this photograph for the Limca Book of Records. Now, this is the biggest that we have seen till now. And this is the post-operative reconstruction that has happened with the help of our plastic surgeons. Again, all these are possible with recent advanced reconstructive procedures. Again, in the field of gynecology, we have seen the oral surgery, the gastrointestinal surgery, breast surgery, and in gynae cancer surgery also we have the minimal invasive laparoscopic surgery. When we do minimal invasive laparoscopic or the robotic surgeries, the extent of lymphadenectomy is the same as was in an open surgery. Hence, the chances of lymphedema is still the same. And that is where the rehabilitation program needs to pitch in. Coming to limb salvage surgery, we are now doing, instead of these patients around 2 or 3 decades back, they were subjected for amputation straight away, but now we are doing reconstructive procedures. This is the giant cell tumor of the distal femur and the preoperative X-ray. Now the radical resection, limb sparing resection has been done, and an implant has been put, and this is the post-operative recovery of the giant cell tumor. So coming to, if I am saying that we have really advanced in our operative procedures, not being that radical as we were before, then why is there a need to focus on rehabilitation? Now, the need for rehabilitation is very simple. Now, these are the pictures that I've got from my patients when they visit me in my outpatient department, and they are signifying with 5 or with 10 that they have survived for 5 years and 10 years. And in my clinical practice, let me tell you, the complaints shift from survivorship to individual experiences. And that is where the rehabilitation comes into place. In the first 1 year, the worry, the scare is of cancer recurrence. But as soon as 1 or 2 years pass by, the patients start getting complaints of pain, contractures, limping, scoliosis because of the shift of the center of gravity, because of the weight imbalances on the 2 sides, and things like that. Now, that is what we need to really focus on, because survivorship is increasing. So is cancer. The cancer numbers are increasing, and so is the cure rates. So we need more robust rehabilitation programs, not just because the cancer is increasing and so is the survivorship, but elderlies are now being treated for cancer as compared to before, wherein we used to just simply negate them from being treated because of minimal invasive procedures, robotic cancer surgeries. Now we have operated upon esophageal cancers wherein the patient is 84 years of age. Right now there is a patient who is coming to my OPD, and we are discussing to operate upon him, who is 83-year-old for a upper rectum cancer surgery. And we are offering him minimal invasive and robotic cancer surgeries. Now, elderlies are being treated for cancer. And we cannot leave these subset of individuals. Our, our lives are increasing. We are having more survivals now. Our reconstructive procedures are on a rise, and hence more expectations is now more demand uh, on their cognitive or their speech. For example, I've shown you photographs of oral cancer surgeries, wherein patients need presently, then if a patient is having a tongue cancer, 15 years back, we used to just primary close the tongue, and we never used to expect much out of the tongue. You know, that he may not get enough of speech or deglutition. But now, with reconstructive procedures, patients are getting back to normalcy. You could see that photograph of a tongue cancer. Now, this looks almost like a normal tongue for this patient, and he demands that I need a good speech. I need a reasonably good swallowing. So it is our responsibility to comprehensively treat these patients. And it is not anymore about survivorship. It is also about living their life as a person. And that is where the rehabilitation comes into place. As compared to what our parents were, I'm not very old though, but as what our parents were, the mothers were not really working. But now, I think 70 to 80% of females in households are actually working. They need to go back to their offices, and they need to work. So rehabilitation programs need to become more robust. So what is the problem statement? This is something which was very disturbing to me, and I really thank Dr. Nitesh for making me realize that. Now, this is the journal that this was a publication from Southern India in Journal of Indian Association of Physiotherapists in 2018, where 50% did not know that physiotherapy is actually required in the rehabilitation program for their patients. And 1/3 were advised or referred, just 1/3 of them. Really troubled to see these figures actually. And when the patients were asked, 2/3 of them actually benefited. Now, we really need to push this program. And in the same study, 63% cancer survivors reported the need for at least one rehabilitation service. And 43% of them said that physical therapy is the most requested service amongst all. So there is a demand, there is a need in at least 2/3 of patients who need rehabilitation. If you ask me, when I perform lung cancer surgeries and esophageal cancer surgeries, I am very, very thankful. Every day I meet my physiotherapy team members, and I really am obliged to have such a wonderful team who takes care of those complications. I do radical surgery, leave that patient to have developed pneumonitis, but they are the ones, you are the ones who actually solve that for me. Unfortunately, I get the credit from the patient, but really, hats off to you guys. Now, the real problem statement lies here. The treating physician's recommendation was associated with a high chance of having physical activity, which suggested that the role of primary treating physician had the maximum influential role. Now, I feel that instead of educating just the patients, you also need to educate doctors and surgeons and physicians, cancer surgeons like me, to actually refer and actually push these patients for a rehabilitation program. Eventually, what are we doing in oncology? Oncology is zero without a teamwork, because only a teamwork can bring good quality. And that is why where the nursing, the rehabilitation programs, the psychosocial support group, who is actually left behind or probably overlooked, is the most important part of the whole gang. Now, what does rehabilitation do? I don't need to tell you, you guys are the expert. They maintain optimum respiratory function early post-operative period. They prevent muscular atrophy, increase the range of motion, prevent joint contractures, reduce pain, and prevent complications, especially in the immediate post-operative period. Also in the later half of the surgery, such as lymphedema, incontinence, pulmonary complications like atelectasis, consolidation of the lung, circulatory complications such as deep vein thrombosis, pulmonary embolism, skin changes, especially after radiation. Speech therapy can really help these patients of oral cancers to reboot themselves. Swallow, deglutition therapy, and so on and so forth. So there's a huge armamentarium for the young physiotherapists who are actually looking at these at today's webinar. There is a huge amount of scope in cancer surgery rehabilitation program. Physical therapists, occupational therapists, speech therapists for oral cancers, physiatrists, lymphedema therapists, cognitive psychologists, recreational therapists, and exercise physiologists are the ones wherein one can really branch into and specialize into these fields and to provide good quality and meaningful care to these patients. Now, this is what I have done. I have salvaged a limb theoretically. What you do, you actually make it into practice. And that is what matters to a patient. And that is what the whole oncology community needs to realize and understand. Well, this is a quote that I was sharing with Nitesh that, in the flow of the presentation, I really realized the importance of it. So I made a quote out of myself. It may not sound that good, but this is what I really felt from my heart, that journey of a patient, the patient I have treated, but the journey is when you, the physiotherapist community, the rehabilitation expert, convert that patient who I have treated into a living being, into a person. And that is what I would say is the definition of rehabilitation for a surgeon like me, a radical surgeon like me. Well, the Indian Cancer Society also went on to say that it's not enough to add years to life. It is equally important to give quality of life to the added years. So I would just like to take the opportunity of this platform and thank to my buddies back in my college days, my post-grad days in AIMS, and in Max, which is the team led by Rohit, Latika. I don't want to name, the fear of losing out on names. So to a buddy who has always had my back, we just do the surgery and we just forget the patient. You actually bring the person, the living being out of him. So thanks to all of you. Thanks.
Thanks a lot, Dr. Archit, for your brilliant talk on surgeon's perspective on palliative care in cancer. Although you cannot hear our loud applause, we much appreciate your time and effort, and as well as for recognizing the role of physiotherapists in cancer care. Thank you very much. And now allow me to introduce you to our next speaker. Dr. Stephen Samuel has completed his full-time PhD in exercise-based cancer rehabilitation from the Manipal Academy of Higher Education, India in the year 2017. And he is currently working as an assistant professor with the Manipal University. Dr. Samuel's clinical and research work revolves around exercise-based rehabilitation for cancer survivors. He is the recipient of the prestigious Young Investigator of the Year in Cancer by the Multinational Association of Supportive Care in Cancer and the International Society of Oral Oncology. Dr. Samuel currently chairs the fatigue study group of the Multinational Association of Supportive Care in Cancer, and he is a member of the International Cancer-Related Fatigue Guidelines Panel of Multinational Association of Supportive Care in Cancer. Dr. Samuel currently has collaborations with Researchers from some reputed institutes like the University of Rochester, Stanford, MD Anderson, Texas, University of Alberta, and Bond University. He is an advocate for incorporating exercise in supportive care oncology and has to his credit some important publications in this field. Dr. Samuel has been an invited speaker at international and national events and institutes like Stanford University on the topic of exercise-based cancer rehabilitation. And I know that most of you know Dr. Stephen very well. And over to you, Dr. Stephen.
Thank you so much. Thank you, Vincent, for the introduction. Such a pleasure to meet you. Thank you, Dr. Archit, for taking your time and speaking to the physiotherapy colleagues across India who are watching us live. Before I start, I want to be grateful for SIP for organizing this webinar and also for inviting me to talk on this important topic, the leadership at SIP, all of you for actually recognizing that this is a very important topic that needs to be addressed by physiotherapists. So without taking much time, I would just go straight into our topic for today. Yes. So yeah, my topic that I will be addressing today as we attend this webinar is palliative care in cancer from a perspective of a physiotherapist. And Dr. Archit spoke to you from the perspective of surgical oncologist, and we are going to explore some of those areas that have been vastly unexplored by physical therapists. Um, the first thing that I would like to do as I start off this presentation is to break the myth. Often as physiotherapists, when we hear the word palliative care, the first thing that occurs to us, the first thing that we often think that it is limited to end of life care. The second thought that I believe often might be occurring to you that palliative care means nothing but pain management. But I want you to understand the difference. The end of life care is actually hospice care. In 2017, American Society of Clinical Oncology came out with these guidelines that actually mention that palliative care can begin at any point of cancer care, but hospice care begins when curative treatment is no longer the goal. Curative treatment is no more possible, which means the patient has an advanced cancer. So I want you to understand the difference between palliative care and hospice care. Any form of intervention that you can give along the duration of cancer care comes under the domain of palliative care. But when the patient cannot receive any more curative treatment, patient is of an advanced cancer, that is when we call it as hospice care. So this is an update from the 2017 ASCO guidelines. So if we look at palliative care from this perspective, that throughout the trajectory of cancer care, any intervention that you as a physical therapist can give comes under the domain of palliative care. We can understand that as a physiotherapist, you can have a role in pre-op care, post-op care, pre-chemoradiotherapy, during chemoradiotherapy, and after chemoradiotherapy. Dr. Archit did shed a lot of light on the role that you and I play during surgery. And I wouldn't want to talk about the commonly used techniques or things that we are very much aware of. I would want you to take you into areas and domains that physiotherapists, especially from India, have not yet started working in. So I believe this is something which many of you across India must be practicing pre-op care of a patient who's scheduled for a cancer surgery. Now, the first 4 points that I have mentioned, mobility, strength, range of motion, these are all commonly practiced treatment programs that we give our patients, including post-op instructions. But one of the new areas that we as physiotherapists can actually start working in terms of pre-op care under the domain of palliative care in cancer is called prehab, or we also call it as prehabilitation. In the West, this is becoming a very, very common concept. I'll just give you an example. One of the populations that is being now often studied is a lot of patients who undergo colon cancer surgeries are actually prehabilitated. Rehabilitation is nothing but prehabilitation, basically rehabilitation before the surgery. And there's enough and more of research evidence that now indicates that patients who were intentionally rehabilitated before the surgery performed better during the surgery and had a better physiological reserve, and their recovery after the surgery was much better compared to patients who were not rehabilitated. Just to give you a small example, if your surgeon is willing to let the patient wait for another 6 weeks for the surgery, then we take them into a prehabilitation program where we improve the functional capacity of the patient, and then he goes in for an operation, which often does improve the outcome of the surgery in itself, especially in the post-op period. So one of the areas that I want you to understand that we have a very major role to play, and it has not been explored by physical therapists, is prehabilitation before the patient goes in for the major surgeries that Dr. Archit spoke about to us in his wonderful presentation. Again, the next role that you and I have is post-op. I'm sure most of you might be working with patients with lymphedema, shoulder dysfunction. Again, these are areas that are more commonly practiced by physiotherapists across India. So I don't want to go into the depth of it. But one of the areas that we can really work is in improving exercise tolerance, which also has a very important role in the recovery of the patients. So we all know that we have an important role in preventing respiratory complications, like Dr. Pandit was speaking about. The first few post-op days are very important, where we play a major role in preventing post-operative complications. Our role in lymphedema, in preventing postural deformities, maintaining range of motion, increasing the strength of the shoulder, and improving exercise tolerance. Now, this is again another unexplored territory by physiotherapists. As we move further, I'll give you evidence, research evidence, in terms of why I say this is an unexplored territory. By pre-CRT, I mean pre-chemoradiotherapy. I'm sure those of you who are working in cancer centers, you would be seeing a lot of patients who receive chemoradiotherapy. Unfortunately, this is a population that is not really referred for rehabilitation. Thankfully, we at our hospital in Mangalore and Manipal have some amazing oncologists who really understand the role of physiotherapy during chemoradiotherapy. And I would just want to share with you what we do with these patients. One of the things that we can do with them is, again, prehabilitate them. If you've been treating patients receiving chemoradiotherapy, you would realize that by the end of 6 to 7 weeks of chemoradiotherapy, most of them develop severe oral mucositis, severe cancer-related fatigue, and very prominent loss of muscle mass, which we call as sarcopenia. Now, there's enough and more research evidence now coming up from the West. Again, no evidence from India. Research evidence that actually shows that patients who were prehabilitated before chemoradiotherapy performed better during the course of chemoradiotherapy, recovered better. Their cancer-related fatigue was much lesser compared to those who did not undergo prehabilitation. In case we don't have the option to prehabilitate the patient, the next option that we have is during chemoradiotherapy. Now, this first point that I mentioned to you about, which is
Hi, Stephen. Are you there? Hello. I think Stephen has got disconnected, and so by the time Stephen connect back, okay. So it seems Stephen has got some power disconnection. Okay. So as he was talking about palliative care, if Dr. Archit is here, so we can take a few questions to Dr. Archit.
Yeah,
Yeah.
apologies.
So
I
sorry,
think
Stephen is here back again.
I'm so
So we
sorry.
can.
I had a power cut. I'm really sorry. Apologies. Yeah, we're back online. I hope you're able to see my screen.
Yes, we can.
Yeah, thank you. I'm so sorry. We had a power cut here. Yeah, so let's go for it. So during chemoradiation therapy, so oral mucositis is one of those complications which is often ignored. And research at our center has found that low-level laser therapy can play an important role in the management and prevention of oral mucositis. And I believe, most of us have been practicing low-level laser therapy in musculoskeletal conditions. But this is another area that is unexplored during chemoradiotherapy. We have been regularly giving our patients low-level laser therapy, and it's worked wonders in prevention. One of the problems with oral mucositis is that their nutrition levels get impaired, because most of them who are having oral mucositis are on a Ryle's tube. Their nutrition gets impaired, which eventually again has an impact on the BMI of the patient. The next thing that we as physical therapists can focus on during the course of chemoradiation therapy is the management of fatigue. So cancer-related fatigue is another unexplored area that we as physical therapists can use various exercise programs to manage. Another area that we can explore is functional capacity, improving the functional capacity, the exercise capacity, and the quality of life. Again, post-chemoradiotherapy, we have an important role in managing oral mucositis, radiation-induced fibrosis. And I would like to share now some of the research evidence, some of the latest research evidence with you to understand what role can we further play in this domain of palliative care. In 2015, we published a systematic review that tried to find out how many exercise-based interventions have been published for cancer survivors in India. And what surprised us was only 2 exercise-based studies that were published by physical therapists from India, which shows the need for research in this area, which shows that this is surely an unexplored territory. Now, just to give you a clear understanding of why are we stressing so much about exercise and physical therapy during the course of palliative care, is because Dr. Pandit was talking to us about how, because of now advances in cancer treatment, a lot of older patients are now receiving cancer treatment, which was not the case earlier. Also, we have a lot of screening happening nowadays, which means diagnosis is much earlier. So there are 2 main reasons why we would advocate exercise and physical therapy to patients receiving chemotherapy. One being age in itself, age-related exercise limitations, conditions like aging, deconditioning, comorbid disease, and disease pathology and therapy-related dysfunction because of surgery, radiation therapy, chemotherapy, hormone therapy, and all these factors in union eventually impair the various components of the oxygen cascade, which eventually impairs the functional capacity of the patient. And that is one of the reasons we are trying to advocate the use of exercise in cancer, because of these 2 causes: age-related dysfunction and disease pathophysiology and therapy-related dysfunction. This was a randomized controlled trial that we published in 2019, and we included 148 patients in this trial. We tried to understand the effect of aerobic exercise during the course of chemoradiation in patients with head and neck cancer receiving chemoradiotherapy. And we found that patients who exercised, so there was an exercise group and a control group. When we compared, we found that patients who exercised very simple exercises of 20 to 25 minutes of walking program and active resisted upper limb and lower limb exercises with breathing exercises, the exercise group improved in their functional capacity measured by a 6-minute walk test, and the cancer related fatigue that was measured on a 10-point scale, and their quality of life improved, especially the mental component score on SF-36. So one of the exciting findings about this study in this population that was undergoing palliative care was that the mental component scores of patients who exercised were much more than the control group that did not receive an exercise program, which shows that exercise during palliative care can also have an important role on the mental function or the mental health of our cancer patients. Those of you who deal with cancer patients would know for sure that mental health is a big challenge that we face when we treat these patients. So this is an important finding from our study. Now, for those of you who would want to ask me, okay, how do I find innovative ways of giving exercise to my clients? One of the simplest devices that you can use to prescribe exercise right now, especially in terms of this COVID-19 situation, is a pedometer, or we also do have a lot of mobile apps. So this is a systematic review again that we did back in 2019, which was complemented by a non-randomized control trial we did, and we found that patients, women with breast cancer who were given a home-based exercise program using a pedometer had very prominent improvement in their muscle mass and their cancer-related fatigue levels compared to patients who did not receive exercise. So this is something that we can advise to you in this post-COVID-19 era where your clients might not be willing to come to your lab or to the physiotherapy center. Pedometer-based exercise is something that we have recently started exploring in this population, and we are able to find considerable amount of improvement in women with breast cancer who used a pedometer-based walking exercise program during the course of chemotherapy. One of the areas that physiotherapists love to work, one of our core areas, is the muscle. We often talk about, range of motion dysfunction. We often talk about, various forms of muscular dysfunction, but one of the areas that we often forget to address, Dr. Pandit spoke about it, about muscle atrophy or lack of muscle mass. And this is one area that we would encourage our physiotherapy colleagues across India to address. This is again a part of a research that we conducted in 2019 and 20, where we were trying to find out the amount of sarcopenia or the amount of muscle loss that our patients who were receiving chemoradiotherapy for head and neck cancer would have. One of the things that we need to understand is that muscle loss is again, connected with various metabolic problems as well. So if there is a high prevalence of sarcopenia, this is something which is very concerning to us. So let's just discuss with you this data. This data was published in PeerJ. It's an open access journal. You can find it online. We used a very simple questionnaire. Often in India, we might not have a lot of facilities or a lot of devices or equipments that are available in the West. But a very simple questionnaire called SARC-F was used by us in this study, and very simple outcome measures like hand grip strength and BIA and physical performance being measured. So I want you to know that the guidelines for diagnosing a patient to be having sarcopenia are given by the European Working Group on Sarcopenia. So we use their guidelines, and based on their guidelines, we tried to classify them. We found out that at baseline, that is at the start of cancer treatment itself, before chemoradiotherapy started, 31.5% of our patients already had probable sarcopenia. And we found out that at the end of 7 weeks of cancer treatment, 89.4% of our patients had developed sarcopenia. Now, this is a very, very alarming fact. You know, at baseline, we had 31% of them who developed sarcopenia, but towards the end of 7 weeks of chemoradiation, 89, almost 90% of them developed sarcopenia, which very clearly shows that chemoradiotherapy has a very strong impact on the muscle mass. And there is age being one factor, and treatment related toxicity being one factor, causes very, very heavy losses in muscle mass in this patient. And muscle mass loss is an area where we physiotherapists can intervene. We can give exercise programs during the chemoradiotherapy that can prevent muscle loss. And this decline was significantly greater at 7 weeks than 3 weeks. Now, one thing, like I told you earlier, there is a strong relationship between sarcopenia and a host of other adverse events that are linked to the metabolic function of the patient. So that's why it's very important that we as physical therapists do provide exercise therapy during the course of chemoradiation therapy. There's another area that I would like to discuss with you. Dr. Archit was talking about it. That is respiratory muscle function in head and neck cancer, or respiratory muscle function in patients receiving chemoradiotherapy. This is another research that we recently completed, and we are in the process of publishing it. We measured the diaphragmatic mobility and thickness of patients with head and neck cancer receiving chemoradiotherapy, and we measured their respiratory function, that is maximum inspiratory pressure, using the micro RPM device. And we found that that this is the device we used to measure the respiratory function, that is the MIP. And this is so we have we thankfully have a good team of doctors working with us. So this is our sonologist who was helping us with the ultrasounds. So what we found in this research was that although the diaphragmatic thickness was not affected much, but the diaphragm mobility in patients who were receiving chemoradiotherapy for head and neck cancer was affected. The maximum inspiratory pressure, the MIP, and the MEP gradually decreased during the course of chemoradiotherapy, which again is an alarming sign that shows that there is a very prominent respiratory dysfunction that happens only because of chemoradiotherapy. Now, these patients were not post-op patients. They were patients receiving chemoradiotherapy with a curative intent. Now, imagine if this same patient is also, a post-operative, if this patient is also a post-operative, case, he will have more profound respiratory dysfunction. So this is another alarming finding. So I will quickly, so initially when we started off, I was trying to make you understand the difference between palliative care and hospice care. Any form of intervention that you give during the entire course of cancer care comes under the domain of palliative care. But hospice care is nothing but what your role is, in a patient with advanced cancer. And this is a systematic review that we published last month. And I want to acknowledge, due acknowledgements to the postgraduates, Preena and Rachita, who were a major part of this project. And we found out that it's not only during initial stages of cancer, but even during the end stage cancer, we do have an important role. Due to shortage of time, I wouldn't want to go into every single study that was done in the systematic review. You can access this online. But the review question that we were trying to address was that what are the various physiotherapy interventions that can be used in the management of patients with advanced cancer in hospice care, and what is the characteristic, that is dose, duration, and type of interventions in patients with hospice care of patients with advanced cancer. So this is the inclusion criteria, exclusion criteria. You will find this on our article, which is freely available online. So I will just take you quickly to the implication that we would like to share from this systematic review. The clinical implication that I would like to share from this review that we recently completed is that the following interventions. Now, please don't get confused. This is talking about hospice care, that is advanced case cancer, patients with metastasis, patients who have only maybe 6 months, around 6 months that are predicted by their treating physicians. So what research shows is that the following physiotherapy interventions have been found to reduce symptoms in patients with advanced care. Structured exercise program, which had an important role in improving their functional capacity. TENS, which is a very, very important and powerful tool that we have, but unused often in cancer care for pain management. Massage therapy, compression bandaging, and relaxation therapy. These were the most important interventions that we found that physiotherapy research can help us. I believe we are called to do evidence-based practice, and if I were to produce to you evidence in terms of what is your role in end-of-life care as a physical therapist, these are the things that you can do. Structured exercise programs to improve functional capacity. Again, they should be tailor-made. TENS for pain relief, massage, compression, and bandaging for problems like lymphedema. In addition, relaxation therapy, which eventually have also been found to reduce sleep disturbances. One of the things that we often don't understand is that our exercises, and I even shows that exercise has been found to improve sleep disturbances in patients with cancer. Sleep is a major problem that our patients with cancer do face, and eventually all these things will lead to an improvement in quality of life. So just to summarize of what our role is in the entire journey of cancer care, starting from diagnosis to the end of life, we want you to understand that it is not only in shoulder, it is not only lymphedema, but we also have a very, very important role to play in patients receiving chemoradiotherapy. Another unexplored area, like I spoke to you, is the area of muscle mass, where patients have been found, 90% of the patients have been found to develop severe sarcopenia at the end of 7 weeks of chemoradiation. And like I spoke to you, let me summarize. Pre-op, you have a role in prehabilitating the patient, and pre-chemoradiotherapy, again, you have a role in giving a prehabilitation program to the patient. So if you would ask me, what is the takeaway? What is the new thing that you want me to do once I go back to cancer care? One of the things that we would want you to do during palliative care is start treating patients receiving chemoradiotherapy, start using prehabilitation programs for patients undergoing surgery, so that your surgical oncologist has a much better outcome at the end of the surgery. So this is a small summary of what your role is in palliative care. Also, we would encourage those of you who are trained in low-level laser therapy, you have an important role to play even in oral mucositis. So this is a short summary of what we would like to bring before you in terms of our role in palliative care. I think I would like to hand over now to our moderator, Vincent, to share his thoughts and maybe propel a discussion or answer some questions. Thank you so much for your patient listening. And we really hope that this would inspire many physiotherapists across India to pursue this field. I know we're short of time, but if you want to read more, our article is available on ResearchGate, the article that I shared with you, and you can read more about it. Thank you so much for this opportunity. Over to you, Dr. Vincent. You can take over now.
Sorry. Thank you, Dr. Stephen. Sorry, I was in mute. I didn't realize. And thank you, Dr. Stephen, for your enlightening lecture. And Dr. Stephen is one of the few physiotherapists doing extensive research in oncophysiotherapy field. And it is so nice to see many physios in India is now gaining interest in oncophysiotherapy. And one of the course that we are running in Tata Memorial Hospital, so many applicants now, come, and we always having a tough time to select candidates. Okay, and without much delay, I just would like to ask few questions. And so this question for both of you, Dr. Archit and Stephen. Actually, Dr. Stephen, insisted much about rehabilitation. Of course, this is a new thing, and not only in Western world, even in India, in Tata, we are doing at least 4 or 5 studies on rehabilitation. And one of the key issue in rehabilitation is the window period, because as a cancer patient, they need immediate care, and as soon as possible, we need to take care of their cancer. Otherwise, it may be fatal. And how do you address that issue of very short window period sometimes we get? And in that short window period, how are you if it is short versus long window period, how will you change your physiotherapy techniques? That is for Dr. Stephen. And Dr. Archit, you can pitch in how you manage to refer how quickly the patients to get some more rehabilitation per se. Yes, Steve,
Doctor, yeah. So I believe, sorry, again, I had a connection issue. I believe the question is, how do we manage patient if they have a short window period?
Yes. Do you do something different to improve their physical fitness?
Okay. So, there are 2 implications that I can have when you talk about a short window period. One could be that you have a very short contact with your client, which means the patient is with you maybe for a short while in the hospital, or the patient can also be an advanced stage cancer. So talking about physical fitness, if you don't have the patient coming to your lab for 6 days a week or 5 days a week, like I spoke to you, one of the simplest ways that we can use for prescription is using a pedometer or an accelerometer. The latest guidelines say 10,000 steps per day, but obviously our patients will not be able to do 10,000 steps per day. So what we advise is find out from the pedometer how many steps you were able to walk on day 1. For example, if it was 5,000 steps, the best way to prescribe is increase by 10% every week. So if your patient sees the pedometer after going home and says that, okay, I'm walking 5,000 steps consistently for 1 week, so the next target for the next week will be 5,500, 10% of increase. That is one of the simplest ways of prescribing when you have the patient with you for a short window period.
Okay. And Dr. Archit, and how do you facilitate the rehabilitation in your practice?
So thanks, Dr. Vincent. I think it's a very, very important question that you have put up because we're always running against the time when it comes to oncological treatment. Nevertheless, I think I have made a point very clear that the most important thing is to again focus on the patient as a whole. And that is where the multimodal treatment needs to pitch in. So I've written a blog, for example, let's take esophageal cancers. Now, most of the esophageal cancers in India are locally advanced, or they are T3 stage. So they generally go for chemoradiation first, 90% of them.
Yeah.
So as soon as the chemoradiation gets finished, now, of course, the moment we decide in for a chemoradiation, I think within 3 or 4 days, the chemoradiation is planned and the patient is simply sent for chemoradiation. So that is something that I really need to sit and figure out with my physiotherapy colleagues, as mentioned by Dr. Stephen, that pre-chemo radiation, pre-CRT sessions of building up the patient is very, very critical and important. Now, these 3-4 days, how we can build it up, or during the treatment, I think that is a very, very important thing that I have learned today, and I would rather sit and discuss with our physiotherapy colleagues. I've written a blog on rehabilitation and in esophageal cancers before the surgery. Now, I have named it as a golden period. I have not encountered any articles till now mentioning it like that. But the time gap between finishing chemoradiation and starting surgery, now this gap is of around 6 to 8 weeks. Now, this is a huge gap because surgery cannot come before 6 weeks or so. And that is the time wherein I think we should nutritionally build upon a patient. Now, this is the golden period for a surgeon and a physiotherapist also to build upon this patient, because whatever we work on nutritionally, physical exercises, chest physiotherapies, and things like yoga, that's how we keep motivating them. But there's one thing that we generally do is send these patients after the first or the second cycle of chemoradiation. When they are generally entering the 4th week, we send them to our physiotherapy department, and that is where they take care of it. And this golden period is utilized very well, and that is why our mortality rates are almost zero. We must have done more than 210 as the last that I figure out. Our data compilation. We've done more than 210 cases of esophageal cancer surgeries, and we have just had one mortality, which is, I think, very good result. And I would say it's not just because of the surgery, but the multimodal treatment that goes into treating each patient or so.
Yeah, just to
Thank
add
you.
to that, Dr. Archit, there's actually a lot of research data that now also suggests survival of patients who were actually prehabilitated. So mortality and survival. So I think these are really exciting things that we need to really put our eyes onto and make things better for our patients. Yeah, thank you for that input.
Yeah, so I agree with you, Stephen. Actually, now we have enough data to show that not only survival improves, quality of life also improves, and apart from that, even the recurrence reduces in those who are doing regular exercise.
Yes.
Yeah, and unfortunately, every guidelines. After the guidelines, they have found that even the normal population doesn't even come 10 to 20% close to meeting the general guidelines put out by various exercise therapy groups. And even if general population is so less, and think about cancer patients, they are hardly engaging in the exercise actually. And so, just as a follow-up question, to Stephen, many places now they are investigating HIIT, the high intensity interval training. What is your opinion? Do you have any experience in cancer patients with HIIT?
So that is something, thank you for asking that question. HIIT is something which we've been recently thinking of exploring in our patients. One of the advantages of HIIT is greater benefits in shorter time, high intensity interval training, greater benefits in shorter time. And some of the research done in diabetics and even cancer has shown improvement in cardiovascular health. So that is one of the benefits that I believe can be very prominent through a HIIT program. And also the fact that it gives the same benefit that any exercise program of a longer duration would give in a shorter time. So this again is an unexplored territory. HIIT needs to be practiced amongst patients with cancer, especially the fact that a lot of them have common risk factors that are also responsible for cardiovascular events, like smoking, etc. So I believe HIIT can also help improving cardiovascular health in patients with cancer. That is a very, very exciting field.
Yeah, thank you. And actually, in 1970, the first exercise trial was done by two wonderful cancer nurses. That was the first ever exercise trial. That was groundbreaking because it was in 1970s. That time, if there is a cancer patient, just they have to lie down and take rest, not to do anything. And but if you see, even now, many patients are fearful after having cancer to do exercise. And many of the new physios, so those who are entering into oncophysio field, they are also much worried, to prescribe exercise physiotherapy. How do you convince a patient, and what is your advice for new physios? And for Dr. Archit, being a clinician, your word has more weightage for a patient. Do you convince in any way, to undergo physical therapy? How do you convince your patients?
Dr. Archit, I would let you answer first and then I would answer.
Okay. So that's a very, very interesting question, because I contradicted my own community in my presentation. So I am a staunch believer that nutrition, physiotherapy, counseling, social support. Now, these are the pillars on which surgery, medical oncology, and radiation can build upon. Because without this, you are really not treating a patient adequately, honestly. I generally spend 10-15 minutes of extra time and tell them that these are for example, if there's a patient with heavy breasts, and if that patient is undergoing a modified radical mastectomy, over a period of time, you need to, I think a physician needs to tell them that eventually their center of gravity is going to shift, and they may develop back changes, scoliosis or something or the other. And that is how we need to build confidence and explain the patient. And whichever patient I have asked to reach the physiotherapy department, they have reached. I mean, I don't remember even one instance where a patient doesn't go. So I think there's a huge amount of there's a lot of gap between the physiotherapies and the clinicians, wherein these two can actually, a convenience of marriage can happen between the two faculties for the benefit of the good, for the benefit of the large. So a physician has to be very, very clear in sending that patient to a physiotherapy department for a good rehabilitation process.
So I believe that, people like Dr. Archit have a very important role in that, in facilitating our role. I will take you back to 2019 when my first ethical committee application. 2009, I applied for ethical committee clearance to perform the first randomized control trial on patients receiving chemoradiotherapy. There was a very respected radiation oncologist on the ethical committee who rejected my application. He said patients receiving chemoradiotherapy cannot exercise. I was a young postgraduate. I went to my guide, Dr. Maya. I told him I am dejected. But by then, my guide had already performed randomized control trials using laser. So he had a good rapport with the oncologist. So we went, had meetings with the oncologist, gave them evidence, and they said, okay, we're taking this risk. If anything happens, you're responsible. So our team said, anything happens, we are responsible. Long story cut short, that paper eventually got published in 2013 and now I think it has 100 odd citations now. So I believe if as physios, we can convince our oncology team, our oncology surgeons, they'll be more than happy, but there's always this initial fight, this initial risk involved. One of the things that we do is we go on rounds with our oncologist. So when our oncologist is taking rounds, one of the physiotherapists or one of the PGs goes on rounds and propose that, doctor so-and-so, we believe this is what we can do for this patient. And once your doctor tells the patient that you have to do this, your doctor is like a god to the patient. Indian patient would listen to anything that the oncologist says. So that is another beauty of working in our center. Our oncologists are pro-physio across Manipal University, and they go into rounds and they tell our patients that you have to do this exercise, which will be taught by so-and-so. And that's how we have found success in our oncology programs. So number one, physiotherapists who really wanted to advocate physiotherapy in cancer, and oncologists who wanted to support and facilitate that. So I believe it's teamwork which will eventually bring about dream work.
Yeah.
So we need
So
people like Dr. Archit.
I must, appreciate the oncologists in Tata Memorial Hospital because they are so supportive. And as Stephen said, the advocacy, physiotherapists must take a step forward, and definitely your oncosurgeons and oncologists would really will be happy to help you out, and and improve patient physio relationship much better way. And I have got a comment from Neeta J. Vyas. I would like to read. I am a cancer survivor, Dr. Neeta Vyas, physio. I am working with cancer patients. It's what I experience. I learned myself by questionnaire from patients and going for total rehabilitation program for patients from pre-operative to till they complete the therapy, and then home programs with good quality of life with continued evaluation during chemo and radio. Thank you, Dr. Neeta JVS, for your comment, and we appreciate. So one more question I would like to ask both of you is about the, patients most of the time, they don't openly come and give you all their symptoms.
Yeah,
Most of the time they try to hide, especially our Indian
true.
patients. It is not only in Indian patients. There are so many papers that suggest even in Western culture they try to avoid being a complaint box. How will you get your patient communicate to you as a physician, as a surgeon, as well as a physio, to give all their problems, and how will you allow them to communicate to you? How will you encourage?
Uh,
Dr. Archit, please
Dr. Archit, you can answer first.
answer first.
Hello?
Did you get the question?
No, I couldn't get it because the voice
Yes.
was breaking.
Sorry. Actually, many of the time patients may hide their symptoms. So you don't get the complete picture, even if they are developing lymphedema in their arm after breast cancer surgery, they don't tell you, just to avoid being a complaint box, or you will put them into more medicines or any other treatment. How do you manage that situation? How do you get them speak?
Okay, yeah, this is a very, very practical issue. Yeah, we get that thing very often. So generally the practice at Max, what we do at our OPDs is, we generally have on a breast clinic day, we generally have a physiotherapist in the OPD itself. So invariably that patient goes to the physiotherapist. If not in this visit, maybe after 2 months or 3 months, when the patient has to come back again for follow-up, the patient straight away goes, irrespective of whatever he feels or not. So as a matter of fact, it is a compulsory rotation that the patient has to go through the physiotherapy clinic. And we're lucky to have our physiotherapy department just next door. And it's very, very easy for one physiotherapist to come to our OPD and have a room in our OPD setup itself, in the oncology OPD. So it becomes very, very easy for us. Yes, sometimes, for example, a patient of lymphedema, you can see the swelling coming up, you can see the redness cropping up, and the patient is still very, very reluctant. I generally have a lot of photographs with me, so I just show them these scary photographs. So it becomes lot of things become very, very easy. I mean, we being physicians, we have a lot of armamentarium with us to convince or not to convince a patient to, in whichever way, what I'm talking about.
So yeah, just continuing with what Dr. Archit said, uh, I believe one of the important things is the physio forming a strong bond with the patient. So initially, when I started working in the cancer wards in 2009, I used to dread going to the ward because they would take the bed sheet and put it on themselves the moment they see you, because this guy has come to make me walk. And I still remember one patient yelling at me and saying, I am not sure how long I'm going to live, and you want me to exercise. I'm going to die soon. Uh, so I've heard all bad words in Kannada. We live in Karnataka, so I've heard those stuff. Thankfully, those days I didn't know so much Kannada. But I kept persisting. I would keep going shamelessly without any fear, just because I knew that this was going to make their life better. So I believe there has to be some form of a heart that we have for these patients. And once we establish that relationship, they would do it. And it was a very, very visible improvement. So all of our patients are in one ward. So they started seeing that those who exercised during chemoradiation went home walking, but those who did not exercise went home on the wheelchair. So once they started seeing the visible output, the cooperation improved, and even the nurses started observing this, and they spend a lot of time with the patients. Then as they started telling the patient, you have to walk, you have to do this exercise. So I think the entire referral pathway has to be impacted if we want our patients to cooperate, which would include nurses, the doctors, and the physiotherapists and the patients. That's my word on that.
Yeah. Due to time constraints, and we are going to stop here. There are so many burning questions, and I hope they will ask you through email or Facebook queries. And I must appreciate all your effort, and thank you very much. And I would like to thank the entire team of Society of Indian Physios to have us here and organize this wonderful topic and webinar. Thank you very much. Thank you very much, everyone. Thank you.
Thank you, SIP. Thank you, everyone. Thank you so much.
Thank you very much. Thank you, the society and Nitesh. Thank you very much for this opportunity.
Thank you.